Greetings and welcome to EHA Unplugged, the official podcast channel of the European Hematology Association, EHA.
I'm Eleni Gavriilaki from Thessaloniki, Greece. It's a great honor to chair this debate. We have with us today two well-known experts in the field of TTP, and I would like to give them the chance to ask the question if plasmapheresis is history or not. And first, I would like to introduce Dr. Prof Scully, who will try to support that plasmapheresis is history.
Thank you very much. Yes, my brief is to try and convince you that plasmapheresis is going to be history in the treatment of acute TTP. And the reason for this is multifold. Plasma exchange was first documented in journals in 1977. So it's over 45 years that we've been using the same therapy in patients with acute TTP. And that involves large amounts of blood product, so plasma, some of which is specially treated, but other therapies in some countries not so. And with that brings the risk of pathogen transfer, it brings the risk of anaphylaxis, it requires specialist units, specialist staff to undertake this type of therapy. Moreover, we have to put in large central lines for it to continue day upon day upon day until the platelet count normalises, but not just that, remains normal. In 2019, there were two important papers published. The first was the Hercules study, and that had been the result of almost 10 years of investigation of this use of this special treatment, which binds to the position of von Willebrand factor that platelets normally bind to. Now, why is that important? Firstly, the platelet count normalised much quicker. Secondly, it prevented ongoing small blood clots that we would normally see associated with end organ damage. But thirdly, it made us realise actually in the past patients continued to die despite the use of plasma exchange, and the impact of plasma exchange with immunosuppression hadn't really changed since the mid-1980s. Now, with the use of caplacizumab on the clinical diagnosis of acute TTP or with confirmation of severe ADAMTS13 deficiency, if this can be turned around quickly, we are not seeing the acute deaths, we are not seeing exacerbations and refractory disease. 1 year ago, in 2023, I was very privileged to be able to present in an oral communication the results of using recombinant ADAMTS13 in conjunction with plasma exchange in acute TTP. This was in 3 cohorts. So one cohort just had plasma exchange and placebo, and the other 2 cohorts had recombinant ADAMTS13. And what we saw from this data, albeit not in large patient numbers, in placebo we see the increment in ADAMTS13 and then drop down the following day, often to less than 5%. But the increment was not comparable to the use of recombinant ADAMTS13. Now, clearly, more trials need to be undertaken and need to be completed, and it needs to go through regulatory approval. However, I am confident that we will get into a space where we do not need to use 3 litres of a blood product over many hours, where we will achieve a lesser benefit compared to using 10 mils of recombinant ADAMTS13, which will produce not only comparable results, but likely better results. So in summary, I think our future is using a non-plasma exchange approach incorporating recombinant ADAMTS13, caplacizumab, and immunosuppression, primarily with steroids and anti-CD20 therapy. Thank you for your attention.
Thank you so much, Dr. Scully, for this comprehensive review of the current landscape of TTP. I'm also good to hear the other side of the coin by Dr. Coppo, who is going to persuade us that plasmapheresis is not history yet.
Yes, thank you. So indeed, I'm convinced that in the forthcoming years, plasma exchange will become history. But for now, I'm also convinced that we cannot offer this PEX-free strategy to all patients with aTTP, regardless of clinical presentation and severity, simply because we do not have so many data in the use of this strategy in aTTP patients. So far, we have one single study that reports such experience besides clinical case reports. This study is online on blood since 2 weeks ago only, and it reports only 42 patients treated with a PEX-free strategy. This is a nice work that stems from very serious and experienced teams, but nevertheless, the number of patients reported is quite small, 42, and these patients may not completely represent the whole spectrum of aTTP severity. So we must be wise towards the message this work. So 40% of these patients were patients with a relapse of the TTP. So this means that those patients had a known past history of TTP. So they had an anticipable severe aTTP deficiency, and these patients are typically tightly have a tight follow-up. So I would say that the diagnosis was likely made more rapidly and more easy. So all this to say that we still have a few experience in the management of patients, especially the more severe cases with a PEX-free strategy. This is the first point. The second point is that we definitely need some prerequisites before treating all patients with a PEX-free strategy. Because first, you need to get experience in the diagnosis of patients with TTP. So this means that you have to be familiar with the clinical scores, with the assessment of the severity of a patient with TTP. And you need to have a lab that provides you ADAMTS13 activity in a rapid turnaround time so that you make the diagnosis of TTP versus the diagnosis of other TMAs rapidly. And this is not so easy for every team in the world. You need to have caplacizumab available within minutes to treat the patients rapidly as soon as the diagnosis is made or as soon as the patient is admitted. Because if you don't have capla or either recombinant ADAMTS13, there's no debate. And you also have to have a perfect coordination between all the protagonists involved in the management of these patients, including the pharma. And lastly, and this is more a perspective, I deeply believe that plasmapheresis by itself, so I mean the removal of plasma from the patients, is almost history now, because clearly it has never been demonstrated that the removal of plasma in these patients allows improving the condition. Some claim that plasma removal allowed to remove antibodies against ADAMTS13, VWF multimers, some cytokines, some tumors from the patients, but this has never been clearly demonstrated. And plasma exchange works in aTTP because it allows to make space, these patients, to provide plasma and thereby exogenous ADAMTS13. So now, at the time we have the recombinant form of atorvastatin, it's likely that in these patients, especially in the most ill patients, if you want to supply atorvastatin in these patients, you will just have to provide them recombinant atorvastatin. So I'm convinced that plasmapheresis will disappear in the landscape of aTTP treatment. So in summary, my message is that yes, we are moving to a PEX-free strategy in aTTP patients, but for now, if tomorrow you have to manage a patient with aTTP, keep in mind that we need a step-by-step procedure so that we are safe. It's likely that the most experienced teams will have first to experience this strategy. And this is important to avoid, I would say, spoiling the party in the success of the improvement of aTTP prognosis. Thank you.
Thank you so much, Dr. Coppo. So a couple of questions. First, Dr. Scully, we heard a lot about the severe, very severe cases. Do you have a comment on that based on all your experience in the field, on how can we define these patients?
It's obviously a very acute situation when patients come in, and so we need to keep it simple. The two parameters that we use really are a troponin level above the normal range and a GCS score, Glasgow Coma Scale, anything below 15/15. And that tells us that the patients are severe and may continue to deteriorate. They're simple tests that we can get back quickly and can be done at the bedside.
Thank you so much. That's a very clear answer. And another question, since the field is constantly changing, is how do you monitor TTP patients, and if you think that this will also affect the future? And a second part of it would be, do you think that they need to be treated and monitored in specialized centers, at least for this new stepwise approach?
Yes, this is the point, because the management of aTTP patients is hyper specialized, especially if we consider to manage these patients without PEX. And this is why I was emphasizing that, firstly, PEX-free regimens should be performed by experienced team trained in the rapid diagnosis of TTP versus other forms of TMA, who can have rapidly caplacizumab available or soon the recombinant atorvastatin, and who are able to manage these patients tightly, typically in intensive care units. So there is a sum of many factors that need to be present so that this PEX-free strategy will be a success.
Thank you so much both for this great debate that I hope will reach to an agreement at the end. So please, closing statements from Dr. Scully.
I think we are on the same page, even though we are opposite sides in the debate. We can't not use plasma exchange at the moment, but will it be history? I very much hope so. We have to move away from blood products treating this acute condition and use non-blood related therapies that act quicker.
Yes, and indeed we all have the hope to see the disappearance of at least plasmapheresis from the therapeutic landscape of these patients. We just have to keep in mind that with the current treatment for these patients, plasma exchange, immunosuppression, and caplacizumab, we can reach up to 99% of survival. So this is a challenging result, and it will be challenging to do better with a decrease in the burden of care. So let's go step by step in the new procedures.
So we have reached an agreement, I think, that plasmapheresis will be history eventually, and TTP, and maybe we have the advantage to focus on long-term follow-up of these patients.
So I won.
Yeah. A second question would then be, what is your opinion on the cost of current treatment in TTP? Dr. Scully?
It's a very important question. TTP care is expensive, regardless. I think you're alluding to the cost of caplacizumab, which in some countries has resulted in clinicians not using therapy. As clinicians, it's not our job to dictate cost. Our job is to ensure that the treatment is effective and safe for patients, of which caplacizumab is in both situations under specialist oversight. So do we use it? In the UK, we use it up front on confirmation of an ANAP13 deficiency, but that's because we have a network nationally that authorises that behaviour. We shouldn't be using it in the refractory scenario. You've missed the boat, and we don't know how patients deteriorate, but we should not be commenting on how much or little a therapy costs.
Yes, the other point is that we have some room to decrease the global cost of TTP management. First, we are now very efficient in the prevention of relapses, and this will modify the studies about cost effectiveness of the management of these patients. Second point is that works are ongoing to better optimize the immunosuppression in these patients to shorten as far as we can the duration of treatment with caplacizumab. So we are talking about PEX-free regimens. So this means for the patient substantial decrease in the burden of care, and this has to be put forward absolutely.
So thank you, Dr. Gavriilaki, Professor Scully, and Professor Coppo for this fascinating debate and for sharing your expertise with us. And thank you to all of you for tuning in and listening.